My name is Dr. Hakeem Yusuf. I'm a consultant in intensive care medicine in Glenfield Hospital, Leicester. Today, I'm going to talk to you about fever in a returning traveller in the context of the MRCP Part 1 exam. International travel to tropical destinations has become very popular both in the UK and all around the world. The main reasons for traveling are tourism and visiting relatives and migration. 10% of travelers will seek medical attention whilst abroad or after returning home from their travels. The common causes in the context of Europe and the UK of common causes of a fever in a returning traveller are malaria, enteric fever, of which typhoid and paratyphoid fever are common causes, dengue fever, HIV seroconversion, rickettsial infection, but you can also have non-tropical infections which are common locally, such as UTIs, pneumonia, influenza, EBV, Epstein-Barr virus, and cytomegalovirus. Please note that when travelers are returning with a diagnosis of a urinary tract infection or a pneumonia, the flora causing the infection will be different from the local flora, and hence special consideration should be taken in selecting antibiotics for treating these infections. The epidemiology of fever in returning travelers is centered around the most common cause of fever in returning travelers, which is malaria. Approximately 1,500 cases of malaria are imported into the UK annually, and travelers visiting friends and relatives overseas account for more than 70% of cases. Unfortunately, 5 to 10 cases result in mortality every year, and most of this is chiefly due to delayed diagnosis. Hence, a high index of suspicion is required when treating a patient who has arrived recently from a foreign destination. The key is in the assessment, and a very detailed and structured history is required. You need to have an appraisal of the countries visited and transited through, and you could access information about the common infections in the destination countries, and also about any current worldwide disease outbreaks. This can be obtained from the WHO website or from specialist country travel websites that might provide information. The dates of illnesses and disease onset are really important. It could give a clue as to what kind of disease you're dealing with. Generally, symptoms occurring within a month of travel, of leaving the tropics, are likely to be as a result of a tropical disease. However, diseases like malaria could present several months later, especially the non-falciparum malarias, Plasmodium vivax and Plasmodium malariae. Information about pre-travel vaccinations and malaria prophylaxis is very important, and also the type of travel. Was it travel for work? For example, patients who have gone abroad to work in healthcare settings may be prone and exposed to certain type of diseases, or is it for tourism? And with tourism, you want to know what kind of activities they've taken part in their holiday, which may give you a clue as to where the pathogens might have come in contact with the traveler. You also want to have an idea of the risk of viral hemorrhagic fever, and later I'll talk about how we assess this. But also very important is to have an idea of the patient's immune status. HIV positive patients may want to go on holiday, and they particularly might be at increased risk of certain opportunistic infections such as malaria, visceral leishmaniasis, and invasive fungal infections, especially if their HIV disease is not well controlled. Now, in terms of activities that could potentially predispose travelers to tropical infections, I've listed a few here. Working in hospital and refugee camps, which we've seen of late with hospital workers and healthcare workers going to tropical countries to help out in pandemics, they could return with diseases such as TB, HIV, viral hemorrhagic fevers, and typhus. Sexual exposure, there is a high risk of sexual exposure in travelers because travelers tend to be more carefree when they're away from their base locations, and hence you should look for infections such as HIV, hepatitis B and C, syphilis, and gonorrhea. If you've had a visit to an African game park, tick, typhus fever is something to look out for. If you've had any activities that require freshwater exposure, you may have a patient presenting with schistosomiasis or leptospirosis. Any activities involving caving could predispose patients to histoplasmosis, rabies, and generally fungal infections. Now, areas that are prone to providing exposure to contaminated food and water could expose patients to enteric fever, Shigella, Salmonella, Campylobacter, amoebiasis, or other helminth infections, and hepatitis A and E. Areas where ingestion of unpasteurized milk is common practice could predispose patients to brucella, listeria, and salmonella. Any animal contact could predispose patients to brucella and Q fever, and areas where air conditioning systems have been shut off for a long time and have only been turned on very recently could expose patients to Legionella. Viral hemorrhagic fevers requiring a special assessment. Often these occur in endemic situations, and information about the endemicity is very important when assessing patients who are at risk. Particularly healthcare workers who have been abroad to such endemic areas to help out with the pandemics are at risk. Common viral hemorrhagic fever are listed, but this list is not exhaustive. Now, transmission is usually by person-to-person transmission via bodily fluids, and patients tend to present within 21 days of leaving the countries where infection is endemic. It's really rare in the UK, and it's important that if you come across one of these patients who's at risk of having a viral hemorrhagic fever, you liaise immediately with a specialist centre with a facility that has appropriate isolation facilities. In the UK, this is located in London at the Royal Free Hospital and in Newcastle. On examination, it is not uncommon to not find anything specific. However, you want to pay particular attention to certain signs that may point you in the direction of the diagnosis, particularly if you've got hepatomegaly. It may be indicative of an enteric fever or leptospirosis or viral hepatitis. Splenomegaly could be indicative of malaria or visceral leishmaniasis. Lymphadenopathy could be indicative of several diseases. The urticaria rash could be indicative of acute schistosomiasis or strongyloides. A maculopapular rash could be indicative of dengue fever, HIV, syphilis, typhus, or chikungunya virus. If you have an eschar or a big scar on the skin, it could be indicative of a tick typhus fever. Jaundice could point in the direction of viral hepatitis, malaria, leptospirosis, and the bloody diarrhea may suggest Shigella, Salmonella, or amoebiasis. So you need to have a high index of suspicion and combine your examination findings with your very detailed and thorough history to help with arriving at a diagnosis. Initial screening investigations are listed here, and this could provide a really good clue in combination with your detailed history and examination as to what the diagnosis is, and often at this point you sort of have an idea of what you're dealing with. There is evidence that a combination of thrombocytopenia and splenomegaly have a good diagnostic predictive value for malaria, and also it may point in the direction of dengue fever. Leukopenia could point in the direction of dengue fever, and eosinophilia is generally associated with parasitic infections, including acute schistosomiasis. Deranged LFTs could point in the direction of a hepatitis, either the viral hepatitis or an enteric fever, or leptospirosis. And deranged urine electrolytes could initially just point to a depleted intravascular state, but also could point to causes of acute renal failure, which could include schistosomiasis, but it could also include malaria. It's very important, given that malaria is the most common cause of tropical illness in a traveler, to conduct at least 3 malaria blood films or rapid diagnostic tests over 2 days. Blood cultures are indicated to pick up acute bacterial infections in blood, and then HIV ELISA tests would be indicated with appropriate counseling in patients who are thought to be at risk of dangerous sexual exposure. Urine and stool culture microscopy is really important for picking out ova and eggs of parasitic infections, and serology and PCR for dengue and other arbovirus, including 𝑨𝒃𝒐𝒖𝒕 𝑭𝒂𝒓𝒛 are important. Unfortunately, these tests take a long time to get the results because they are serological tests, and often a high index of suspicion is required in their management. A chest x-ray could very importantly pick up an acute pneumonia, tuberculosis, or reactivation of tuberculosis, and an abdominal ultrasound could confirm findings of hepatosplenomegaly picked up on ultrasound, or if they're not picked up on examination, they could be picked up via ultrasound. It's really important in the management of this patient to have early infectious disease specialty input, as you may not be aware of the special considerations required in managing these patients. As malaria is the most common disease in this context, it's very important to have a high index of suspicion and treat early, as not treating early could make patients progress into severe malaria with really high mortality. Be wary that the drug-resistant malaria is really common nowadays, and actually is much more common in Southeast Asia, and so it's really important to actually consult guidelines in how to manage this patient. There are guidelines on the British Infection Society website, and the link is provided on this slide. Importantly to note that if the malaria has been confirmed as a non-falciparum malaria, it can be treated in an outpatient setting. If it's falciparum malaria, or where you're not sure of the species of malaria, patients need to be treated in hospital. For the enteric fevers, it's really important to be aware of the resistance patterns in different regions of the world. It's well known that resistance to ciprofloxacin is really high in Southeast Asia, but it's uncommon in Africa. So depending on where patients are from, you may want to tailor your therapy. In resistant areas, oral azithromycin has been seen to be very effective, and in patients who are unable to take oral medication, 𝑨𝒃𝒐𝒖𝒕 has been indicated. Just of note, the response to 𝑨𝒃𝒐𝒖𝒕 for enteric fevers is very slow, and recovery could take 7 to 14 days. For rickettsial infections, they're generally very sensitive to doxycycline. However, in the case of diseases such as dengue fever, you may have to combine this with fluid replacement and appropriate supportive care. Empirical therapy is really encouraged, as sometimes specimens can take a long time to yield results, and once you've acquired all the required specimens and have taken some specialist advice, you may want to start empiric therapy just to ensure patients don't progress into a severe form of the disease. All infections in this category require public health service notification. In the UK is a public health agency, and in other countries they require public health notification to allow collection of epidemiological data, but also in cases where a large numbers of these diseases have been picked up, appropriate public health measures can be put in place to prevent widespread infection across the population. Prevention is very important, and patients who are going abroad to enjoy the holidays should be advised to take vaccines for preventive infections, and the sites listed on this slide which can be accessed to look at the common infections and the vaccines required for different countries. Advice on safe sex should be provided, and advice on appropriate food and drink hygiene to prevent enteric fevers. Malaria prophylaxis is an important importance of compliance is really important for patients going to malaria endemic areas, and patients should be advised to take appropriate measures to ensure insect bite prevention. Thank you very much. I hope this has been useful for you in preparation for your MRCP Part 1 exam, and I wish you the very best in your preparation.